Good evening, Dr. Phil here. Today we'll be discussing on heart blocks. Introduction. Heart blocks may refer to atrioventricular block, which is interruption of impulse propagation between atria and ventricles, or bundle branch block, where there is interruption distal to the atrioventricular node. Causes includes intrinsic heart disease such as myocardial ischemia, degenerative processes, infiltrative processes, etc., electrolyte abnormalities, excessive vagal tone, and iatrogenic causes such as iatrogenic after AV nodal ablation or after surgical aortic valve replacement. Most cases of intraoperative AV block are transient and do not require pacing. However, AV block may be persistent or permanent, thus an epicardial pacing system is necessary when AV block develops in cardiac surgery, particularly in aortic or mitral valve surgery. Preoperative management of heart blocks. Indications for preoperative pacing includes symptomatic first-degree heart block, symptomatic second-degree heart block Mobitz type 1, second-degree Mobitz type 2 heart block, third-degree heart block, symptomatic bifascicular block or symptomatic first-degree heart block plus bifascicular block, also known as trifascicular block, and symptomatic sinus node disease. First-degree heart block. Features: delay in conduction through the AV node to the ventricles, prolonged PR interval of more than 0.2 seconds at normal heart rate. Causes of first-degree heart block includes aging, ischemic heart disease, increased vagal tone, drugs such as halotane or digoxin, cardiomyopathy, myocarditis, etc. Management. Most are usually benign, however may progress to second or third-degree heart block. First-degree heart block is not a problem during anesthesia and needs no specific investigation or treatment. Second-degree heart block, Mobitz type 1 Vancke-Buck phenomenon. Features: AV delay, progressive lengthening of the PR interval, and then failure of conduction of an atrial beat, followed by a conducted beat, and the cycle repeats. It is common in young athletically trained adults with a high vagal tone, and may occur during inferior MI and tends to be self-limiting. Management. Asymptomatic patients do not require treatment perioperatively. Second-degree heart block, Mobitz type 1 may rarely proceed to complete heart block. Pacing may be required if bradycardia is severe or causes hemodynamic instability. Long-term pacing may be required as Vancke-Buck block may progress to higher degrees of heart block. Second-degree heart block, Mobitz type 2. Features includes intermittent atrial depolarization without a subsequent ventricular beat, sudden block below the AV node, PR interval may be normal. This block may occur regularly. 2:1 or 3:1 are common forms. Second-degree heart block, Mobitz type 2 often progresses to complete heart block. Management. Pacing may be required if bradycardia is severe or causes hemodynamic instability. If surgery is urgent, this may be achieved quickly by inserting a temporary transvenous wire prior to definitive insertion. Third-degree heart block or complete heart block. Features: complete failure of conduction between the atria and ventricles. P waves are discordant with QRS waves. Independent atrial and ventricular activity occurs, with the latter arising from an ectopic site. Ventricular rate is usually slow, especially if the ectopic site is far from the AV node. There may be wide QRS complexes with a rate of less than 45 beats per minute. Third-degree heart block is occasionally a transient phenomenon due to severe vagal stimulation, which responds to stopping the stimulation and IV atropine. Complete heart block may rarely be congenital. Possible clinical findings include hypotension, wide pulse pressure with large stroke volume, Cannon waves in the JVP, and escape ventricular arrhythmias. Causes includes OH, ischemic heart disease, myocarditis, cardiomyopathy, cardiac surgery, increased vagal tone, beta blockers, digoxin, hyperkalemia, congenital abnormality, etc. Management. For patients undergoing surgery who have pre-existing complete heart block or predisposing conditions, a pacing wire should be inserted preoperatively. Pacing is usually required because escape junctional or ventricular rhythm is usually very slow at less than 40 beats per minute. If surgery is urgent, this may be achieved quickly by inserting a temporary transvenous wire prior to definitive insertion. Drugs that decrease AV conduction, such as beta blockers and halotane, should be avoided. Isoprenaline 0.02 to 0.2 mcg per kg per minute may be used to increase ventricular rate in complete heart block. Backup pacing box should be available. Cardiac output should be maintained wherever possible. Antiarrhythmic drug suppressing ventricular activity should be avoided. Bundle branch blocks. Mechanism. There is delay in depolarization in the right or left bundle branches, resulting in delay in depolarization of part of the ventricular muscle, resulting in subsequent QRS widening. In right bundle branch block, QRS complexes are more than 0.12 seconds. There are slurred S waves in lead 1 and V6, RSR pattern in V1, where the second R is larger than the first R and may appear M-shaped. There is a small initial negative downward deflection followed by a larger upward positive wave, then a second downward wave in V6. Right bundle branch block is often benign. Left bundle branch block, septal depolarization is reversed, resulting in change in the initial direction of the QRS complex in every lead. QRS complexes are broad. There are broad monomorphic R waves in lead 1 and V6 with no Q waves, broad monomorphic S waves in V1 and may have a small R wave. Left bundle branch block may indicate heart disease. Left bundle branch block makes further interpretation of the ECG other than the rate and rhythm difficult. Bifascicular block consists of right bundle branch block plus block of the left anterior or left posterior fascicle. In right bundle branch block with left anterior hemiblock, this is more common. There is RSR pattern in lead V1. There is left axis deviation. Criteria for left anterior fascicular block includes frontal plane axis between -45 and -90 degrees, QR pattern in lead AVL, R peak time in lead AVL of 45 milliseconds or more, QRS duration of less than 120 milliseconds. For right bundle branch block with left posterior hemiblock, this is less common. Right bundle branch block with an abnormal degree of right axis deviation. Other causes of right axis deviation should be considered. Criteria for posterior fascicular block includes frontal plane axis between 90 and 180 degrees in adults. However, owing to the more rightward axis in children up to 16 years of age, this criteria should only be applied to them when a distinct rightward change in axis is documented. RS pattern in lead 1 and AVL, QR pattern in leads 3 and AVF, QRS duration of less than 120 milliseconds. Trifascicular block consists of prolonged PR interval together with a bifascicular block. Bundle branch, bifascicular, or trifascicular block will rarely progress to complete heart block during anesthesia. It is not normal practice to insert a pacing wire unless there have been episodes of syncope. Intraoperative heart block. Atropine is rarely effective but could be tried. Isoprenaline is useful if hypotension is profound. The alternative agent is adrenaline. The dose for IVI isoprenaline is 1 to 10 mcg per minute. Pacing may be required if bradycardia is severe or hemodynamic instability occurs. Transcutaneous pacing may be practical in the operation theatre if electrodes can be placed. Esophageal pacing is also effective. The electrode is passed via the esophagus and connected to the pulse generator. Adjust the position until there is ventricular capture. Transvenous pacing is both more reliable and effective and relatively easy. Steps. The PAFC introducer of adequate size is used to pass the wire into the internal jugular or subclavian vein. This can be done while other equipment is being collected. Insert balloon tip pacing wire to the 20 cm mark and inflate the balloon. Connect the pulse generator at 5 volts. Advance until ventricular capture. When ventricular capture is achieved, deflate the balloon and insert a further 5 cm of the catheter. If the 50 cm mark is reached, catheter is coiling up or not entering the heart. Deflate the balloon and withdraw to the 20 cm mark and try again. These are my references. Thank you.